Welcome to our session today. Hi, my name is Jordan Sexton. Welcome to the workshop, Graft-versus-Host Disease, What to Do When It Attacks the Lungs. Before we begin, I'd like to thank Incyte Corporation and Sanofi, whose support helped make this workshop possible. It is now my pleasure to introduce Dr. Guang-Shing Cheng. Dr. Cheng is a pulmonologist at the Fred Hutchinson Cancer Center in Seattle, Washington. She focuses on improving outcomes for cancer patients who have respiratory failure and lung complications related to their cancer treatment. Dr. Cheng is developing new ways to prevent lung damage and improve lung function in these patients. Her main interest is lung GVHD, a serious complication of blood stem cell transplantation. Please join me in welcoming Dr. Cheng.
Thank you so much, Jordan, for that introduction. So we're going to talk about GVHD of the lung today. So basically, I'm going to review the basic knowledge of BOS, or bronchiolitis obliterans syndrome, which is a manifestation of GVHD of the lung. We'll talk about treatment of BOS, and then also review some other lung conditions that are probably related to graft-versus-host disease. So a lot of things can happen in the lungs after transplant, and bronchiolitis obliterans is one of a spectrum of other of these diseases that are non-infectious that can happen. We do think that bronchiolitis obliterans syndrome is a manifestation of GVHD, whereas some of these other entities, including interstitial lung disease, organizing pneumonia, may, in some instances, also represent graft-versus-host disease, though sometimes it's not entirely clear because these conditions can happen for other reasons, including drug toxicity. And then there are effects of graft-versus-host disease that can affect the chest wall and your musculature that can affect how you breathe, as well as disease of the pleura, or the lining of your lungs and your chest. Late onset non-infectious complications are actually really pretty common after transplant. About 20% of transplant survivors will experience one of these entities in their survivorship. So I just wanted to get everybody on the same page as to the anatomy of lung tissue. What are we actually talking about? Where does the disease actually affect your body? So for graft-versus-host disease of the lungs, or bronchiolitis, what we're talking about is affecting your small airways. So this is a micrograph or a close-up of a piece of lung tissue, and you have a small airway that goes into the lung tissue, and these little saccular structures, that's the alveoli. That's where your body is able to get oxygen from the air and expel carbon dioxide. So these tiny little airways, they end in these alveolar sacs, this is where a lot of the disease happens in graft-versus-host disease. Other disease, like interstitial lung disease or organizing pneumonia, can affect the alveolar sacs. And also, if you get a pneumonia, like these alveoli get plugged up with infectious material and inflammatory material. So just to remind people of, or show people what it means to have, where the disease actually happens. So bronchiolitis obliterans syndrome, or BOS, starts when your donor cells attack the airways. This inflammation leads to obstruction of the airways and fibrosis, which then results in airflow decline, meaning it's harder for air to go to be expelled, and hence difficulty breathing. The pathology is something we call obliterative bronchiolitis. And these are two examples of pathology specimens of somebody's diseased airway. So you can see in this one on the left that this is an airway that's sort of been narrowed by this extra material or fibrotic material around it. And here on the right, you see that there's an outline of an airway that's been completely obliterated by fibrotic material. That's why it's called obliterative bronchiolitis. Again, this is a lung biopsy, and this is a rare condition that is seen in other disease contexts, including lung transplantation. So what is the clinical course of BOS? This is an example of one of my patients, and it's actually fairly typical how this presents. Of course, it's a little different in everybody, but oftentimes it might present as something that is could be it might start off as like a cold or cold symptoms. Sometimes people get antibiotics to treat that, or it's presumed to be a pneumonia. They do okay, and then a couple weeks or months later, their lung function falls. They have a persistent cough, and then BOS is diagnosed. After the initial diagnosis, people sometimes might improve a little bit, but with a lot of the immunosuppression, there might be increasing difficulties. People sometimes get hospitalized with other infections, and they need to get on second-line treatment. Treatment generally does help the symptoms, but the lung function generally does not recover fully, and it will stabilize, but BOS is punctuated by periods of worsening symptoms, generally due to infections. So it happens a little bit differently for everybody, but for most people, your lung function actually plateaus, as seen in this what we call a spaghetti plot, that after diagnosis, which is day 0, most people are flat, meaning the disease is more or less stable or has kind of already, the damage has already been done at this point. But people can have different trajectories. So this is the period where you want, if this is going to happen to you, you want it to be diagnosed earlier before you get all the way down with a lot of lung dysfunction. And this is the window of opportunity for early diagnosis often happens when people don't have symptoms yet, because you have to lose a lot of lung function before you get symptoms. What are the risk factors for BOS? Well, having chronic graft-versus-host disease elsewhere, like even mild chronic graft-versus-host disease, like that shows up in your skin, is the primary risk factor. It occurs in 14% of people who have GVHD elsewhere, and it's usually diagnosed within 6 months of your initial GVHD diagnosis. We can see changes in lung function measurements at day 80 or 100 that could potentially predict the occurrence of BOS, but these changes could also mean lots of other things. But having lung function change at day 80, 100 is a risk factor. Some conditioning regimens, such as those that include busulfan, are also risk factors. And then prior lung disease and low immunoglobulins have been shown to be risk factors. The low immunoglobulins probably predispose people to infections. So, and it's also important to know that we think that specific respiratory viruses increase one's risk for BOS. So this is knowledge that comes from two retrospective studies, and right now I'm doing research to look at this in a prospective study, that if you have lung dysfunction after a respiratory viral infection, you're more likely to not do well long term. The specific viruses that we think impact BOS include respiratory syncytial virus, para-influenza virus, and COVID-19. So it's important to get vaccinations after transplant. The diagnosis of BOS depends on pulmonary function tests. And so transplant survivors, I think most of you are familiar with the PFT lab, and the diagnosis is predicated on a new decline in spirometry compared to your prior PFTs. And this is just a little graph showing that when you blow out on this red line, it's scooped, meaning that air is having a hard time coming out of your lungs, whereas normal should be this nice, smooth, convex line. And this shows us that there's evidence of airflow obstruction, but the airflow obstruction should not be due to other lung diseases, including asthma. You shouldn't have an active lung infection, and it's usually accompanied by other signs of graft-versus-host disease in other parts of your body. For diagnosis, the CT scan of the chest sometimes will show so-called air trapping, where they can see these areas where it looks like too dark, that the air is not leaving the lungs properly. Sometimes you can get dilated airways, which is a sign of late disease, and this is also called bronchiectasis. So those are confirmatory pieces of information that help us hone in on the diagnosis. And then bronchoscopy is often performed to rule out infection, and this is actually important because infection can complicate the lung function and also promote BOS. So it's a minimally invasive way to sample the lung tissue with installation of saline. This is called lavage. And biopsy can be performed if necessary, but often we forgo this because that's a little more risky than just doing a lavage. And generally, people tolerate it as an outpatient procedure. So the early diagnosis of BOS really depends on getting your monitoring PFTs after transplant, because as I mentioned before, symptoms don't generally develop until a lot of lung function has been lost. So this is a picture of my nurse practitioner, Maggie Guerrero, who's my right-hand person in clinic, doing a lung function test. And you can see that, by the time somebody has onset of symptoms, their lung function has already gone down quite a bit. So we want to try to catch people in the early phase, which means that after transplant, one should be getting routine PFTs after at 3 to 6 month intervals. Certainly, everybody post-transplant should have one yearly, before transplant, day 80, 100, 6 months, and then annually thereafter. And if you have chronic GVHD, you really need one at the time of your GVHD diagnosis. Every 3 months, particularly while you're on immunosuppression. So how do we do spirometry to make it easy on people? So spirometry is the act of, blowing out and measuring your lung function. You can do it in the PFT lab with a technician. This is supervised spirometry. And now we have these handheld devices where one can do them at home at more frequent intervals, including these handheld portable devices. And I just wanted to show people that now we have the technology with these individual Bluetooth battery-operated devices that sync to your smartphone, and you can do them in the comfort of your own home at whatever interval is recommended. But certainly, this allows people to do it more frequently than every 3 months. And this is just to show you that the cloud-based telemonitoring schema, which is now commercially available, that you do your measurement, it syncs to your smartphone, the measurements go to the cloud, your doctor or your care team can look at it on the portal and then send you an alert if something doesn't look right. Okay, so now I'm going to move on to treatment and just review what we do if somebody is diagnosed with BOS. The current backbone is this regimen that I call FAM plus LABA that's Fluticasone, which is an inhaled steroid, Azithromycin, which is an antibiotic that many of us know, Montelukast, which is a daily anti-allergy pill, and a long-acting beta-agonist, or LABA, which is a bronchodilator. This helps open up airways, twitchy airways. And this regimen is based on 2 clinical trials that were published now about 10 years ago. And whether or not most people will also get prednisone at a relatively high dose for 2 to 4 weeks, followed by a taper. The question does come up, is azithromycin actually safe for BOS? And why does this come up? Because there was a clinical trial done, this was 2017, now 8 years ago, that looked at azithromycin as a prophylactic agent. People were given azithromycin just at the start of transplant. And then the hypothesis was that this would prevent people from getting BOS or lung GVHD. The trial was stopped early because that actually did not happen. And what happened is that the people who got azithromycin actually were dying more because of relapse. So you can see here on the rightmost graph that the people who got azithromycin died sooner than people who didn't, who got placebo, and it did not prevent the occurrence of BOS. Why is that? It's still being worked out. We think that azithromycin might actually impact, the control, the GVHD sort of cancer surveillance mechanisms. But generally, azithromycin is otherwise a safe drug that is used for many things. So how does that impact, the regimen that we use? Well, just to mention that, inhaled corticosteroids, this is probably the mainstay of what makes this treatment effective because it's hitting the initial inflammatory aspect of lung GVHD. It is associated with a small increased risk of pneumonia and other obstructive airways diseases, so we do have to think about that. And some people just simply don't like it, but it's generally well tolerated. The long-acting beta-agonist is probably not necessary after the first month, but this is really for symptomatic relief. It's not disease-modifying. And then what do we do about azithromycin? Because azithromycin itself is a very good sort of adjunctive anti-inflammatory. Like we're using it as an anti-inflammatory as opposed to an antibiotic, and it is effective in other airways diseases. So we measure the risk of subsequent malignancy with, sort of not a lot of evidence for its effectiveness in the treatment of BOS. And then Montelukast probably doesn't have a lot of major effect, but it's not, it's very well tolerated and not harmful. So my practical approach is to avoid azithromycin if you're less than 1 year post-transplant, if you're a high-risk AML, ALL for relapse, and then to generally discontinue it in 3 to 6 months. And then if people are stable, then I discontinue the other medications in a stepwise manner. And the inhaled corticosteroid is the last thing that I'll take off. But generally, people will be on this regimen for probably at least, 6 to 18 months, if not longer. There are now additional treatments that we can give for BOS, and that includes the things that we give for GVHD in general. And, extracorporeal photopheresis is certainly something that we can use as a steroid-sparing approach, but often not practical for people. The last couple of years has really been, we've been fortunate to have new agents approved, including ruxolitinib or belumosudil that patients probably know as Jakavi or Rezurock. And now we have axatilimab, which is another option. In addition, there are FDA-approved medications that are specifically meant to treat pulmonary fibrosis. And because there is a fibrotic component, this is important to know. And that includes an agent called pirfenidone and another one called nintedanib. So just briefly to review the evidence for Jakafi, this agent is an anti-inflammatory, and we just completed a phase 2 trial with 49 patients with newly diagnosed and established BOS, and roughly a third of participants, particularly those who had new BOS, had improvement in their lung function at 3 months. And you can see here on this graph on the right that those patients with the red line are those participants who had an improvement in their lung function trajectory. Those who were established BOS were generally stable, and it was reasonably well tolerated. So this just came out, and while we don't see a response in everybody, at least a third of people had some improvement, which is encouraging. And then I just want to mention Rezurock. So this, again, has already been FDA approved for other GVHD. Really well tolerated, and we think that it might have some benefit in people with BOS specifically. So we are running a trial. So my colleague, Dr. Corey Cutler at the Dana-Farber Cancer Institute, is leading this study called the BBOP study, and I encourage you to check it out. And we're enrolling here at the Hutch at University of Michigan, and also just want to mention that Stanford will open as well. So this is for new onset BOS and BOS prevention. Also wanted to mention pirfenidone. This has tested. We published this recently, and there are, it was well tolerated, and long term, actually, about 40% of patients had some improvement in their lung function long term. What do we do if your lung function continues to decline? Well, we do look at the exacerbating factors, including, do you have an infection? Is it reflux causing worsening lung function? The usual workup includes a scan, possibly bronchoscopy, and then we would consider second-line treatment. And then, my advice would be to go for a clinical trial if one exists, which is, there aren't that many of them out there now, but we're working on it. Consider a prednisone burst, a new GVHD agent, or a pulmonary antifibrotic. And then a lot of times, we're kind of stuck with really simply supportive care. People will plateau and be left, things won't decline any further, but they are still affected. And so we will go for these supportive care measures, which I'll get to. And that may also in some instances include supplemental oxygen. So as I mentioned, the other adjunctive treatments for breathlessness include bronchodilators, albuterol, formoterol, and muscarinic agonists such as tiotropium or Spiriva, and then supplemental oxygen. We want to prevent and treat infections, and like I mentioned, vaccinations are really important, and other exacerbating conditions like sinus disease and reflux and other allergies. Airway clearance is important for people who have a chronic cough, and this doesn't happen to everybody, but some people have chronic cough that's productive because their airways are distorted. And so things like positive expiratory pressure devices, such as this acapella device, can help clear secretions and improve these symptoms. And then pulmonary rehab, yes, for people who have a lot of symptoms or are on supplemental oxygen, I do recommend pulmonary rehab. And this really helps not necessarily with improving the lungs themselves, but improving all the other parts of your body that participate in breathing. So it's important to keep your strength up. And this rehab, pulmonary rehab, it happens differently in different places, but it generally consists of education, some fitness, and breathing exercises. Okay, so then I'm just going to spend just a few minutes on other lung conditions that people might get. And one of them, importantly, is something called organizing pneumonia. And this condition occurs when the alveoli are attacked and filled with inflammatory material, like you can see on this CT scan. It can present like infectious pneumonia, but it can also occur after a lung infection. And this was well described after COVID-19, but we had this even before COVID-19. And patients with a history of acute and chronic graft-versus-host disease are certainly at risk. The good thing about organizing pneumonia is that it's generally responsive to treatment, and the first line treatment is prednisone. So I think a lot of people suffer more from the prednisone than from the disease itself, unless it lands them in the hospital. Unfortunately, one does need to be on this agent for quite a long time to avoid relapse. And, it sort of depends on the burden of the disease. But, for those who can't tolerate the steroids, inhaled steroids or some of the other agents like Jakafi or mycophenolate mofetil could be effective. And I also just want to mention that, for those people who have sclerotic GVHD, this can really affect their breathing, primarily through skin tightening of the abdomen and chest. And then GVHD can also affect your respiratory muscles in the form of myositis. And also prolonged steroids for the treatment of GVHD, can cause overall weakness and respiratory muscle weakness. So it can be very complex, people's shortness of breath and impairment. So these are all things that we take into consideration when we look at people's lung function as well. And then, as I had mentioned much earlier, people can also get pleural disease or pleural effusions, which is inflammation of the lining of the lungs, causing fluid buildup and compression of the lungs. And that can be due to graft-versus-host disease. So I get this question a lot, particularly for people who are haven't been able to recover their lung function and they're really impaired. Can you get some new lungs? And the answer is yes, in specific circumstances. So your lung disease really has to be bad enough, like requiring home oxygen. You have to be, generally most lung transplant centers want you to be cancer-free for at least 5 years without a lot of immunosuppression and no other organ problems. Really need to have adequate weight, social support, and a motivation and ability to do pulmonary physical rehab. So, we don't, we hope that nobody has to go to lung transplant, but but sometimes this is the only option, and something that many centers, lung transplant centers, are starting to be more accepting of stem cell transplant patients who have lung complications as candidates. So in summary, lung GVHD, while uncommon, can be really challenging and can limit people's activities and quality of life. It often starts out without symptoms. So routine lung function monitoring after transplant is really important. One is more likely to prevent lung function loss if it is treated early. And there are also multiple additional lung complications related to graft-versus-host disease that we are still learning about. And given that this is a family of rare diseases, what we're doing is, a lot of it is We are really trying to study it and understand it and get people the right treatment and to prevent the quality of life consequences. All right, so with that, I'll open it up to questions.
Good deal. Thank you very much, Dr. Cheng. That was an excellent presentation. So if you have any questions in the audience, please use the chat box on the left or the Q&A form on the left, and we'll get to as many as we can. But let's get started here. So the first question I have for you, thank you so much for your talk. When you consider the progression of BOS, is it accurate to consider that after the anti-inflammatory processes, then the fibrotic processes occur?
When we consider progression, it's accurate to consider that after the inflammatory process, then the fibrotic process occurs. Generally, that is how we conceive of it. However, I think what is happening is that in many cases, there's probably a concurrent inflammatory process with fibrosis, and sort of the relative proportion or the, how would you say, like the sequence of biological events is really not well worked out. Because if it were simply, yeah, right, so if there's simply just inflammation, it should be stopped with, prednisone, okay, or ruxolitinib. But yes, that is correct that we do think that for people who are progressing, that the fibrotic process is kind of running away, if you will. And it's really hard when it occurs in the lung because the lung itself does not regenerate. So therefore, once fibrosis happens and, the fibrosis, it blocks the small airways, it's really, really hard to get it back. So that's why this is so challenging to treat.
Okay, excellent. Thank you. And do medications like second-line meds and FAM support ensuring that there's not worsening or progression of the disease? You discussed the opportunity to consider weaning off FAM meds. What factors do you consider to initiate weaning? Okay.
So that's a great question because we think that sort of the longer-term agents such as pirfenidone and belumosudil, while they might not work right away because they're, belumosudil actually is a little more anti-inflammatory, but we think that something like pirfenidone probably is there to prevent further fibrosis, and that's what we see in idiopathic pulmonary fibrosis, non-transplant lung disease, okay? The FAM meds, at some point the process stops, and what you're dealing with, just like the skin might stop, right? Or what happens to your mouth stops. That what happens is, in terms of weaning off the FAM meds, my consideration is really the lung function has to be really pretty stable for a good 6 months, and that we think that their other GVHD is controlled. So that's my consideration, and the reason why I don't want to keep people on FAM forever because, number one, the azithromycin aspect because of this association with relapse and subsequent malignancy, which we did show. And then, like the exposure to inhaled corticosteroids long-term, while often it's preemptive, I also don't want to expose people to increased risk of infection, even though that risk is probably relatively small.
But what is the best approach to dealing with a cold? This person feels their immune system ramps up during them, and then their GVHD can be very bad afterwards.
Yeah. Okay. So that is, yes, something that we do observe, and I think that if you already have BOS, then I think it is still using your inhaled agents, and if you're on azithromycin, that's probably an okay time to stay with that. For somebody who doesn't yet have any issues really with their lungs, I mean, it's worthwhile to get a lung function test after it's, your cold has resolved. That's my recommendation. I mean, I would like to have home spirometry be standard of care for people who are at risk, and right now we think that's people who have graft-versus-host disease. So we're working on trying to hone in on that.
And have you seen a significant change in the mortality percentages associated with lung GVHD with new systemic medications available?
Okay. So the mortality, we have not yet, I mean, it's too early to tell right now with Jakafi and Beli-Mostadil. I anticipate that mortality will not be as bad as it was before. And already over the last 15 years actually at our center, mortality from this disease has gone down. And I do actually think that is actually related to earlier diagnosis, because it used to be, so 20 years ago, people in the FAM study were, the median FEV1 at diagnosis was 46%. I mean, you've lost already half of your lung function. Whereas in 2020, when I last, in my cohort, our median diagnosis FEV1 is actually is like 68%. So we've improved over 1.5 decades in recognizing this disease, getting on it early, and the mortality at 2 years is over 70%, or survival is over 70%, whereas it used to only be 40%. So yes, mortality has definitely gone down over the years due to BOS. We have a lot more work to do. I anticipate that with Jakafi, Rezurock, Pirfenidone, these other agents, that it will continue to improve.
Excellent.
And I just want to mention that people can have really, really bad lung function and survive for a long time. You just have to, a lot of people just simply adjust. I know that's not, it's very easy to say and very hard to do, but it's not, we are not nihilistic about this anymore.
Excellent. This person is 11 years post-stem cell transplant and has GVHD of fascia and eyes. They were just diagnosed with early-stage BOS due to chronic cough. They are on Montelukast. Sorry if I pronounced that, or sorry if I mispronounced that. And are there any non-pharmacological recommendations you may have or things they could do?
Non-pharmacologic, I think it's just simply staying active, prevention of infection. Yeah, that's primarily it. And I think avoidance of infection is the primary thing, and just staying active. If there's only, if that person is only on Montelukast, then it's probably pretty mild. Yeah, is my guess.
And would you be able to recommend a prednisone pulse schedule?
Okay, so I'm assuming this is maybe for somebody who's just been diagnosed with BOS. I generally don't give more than 1 milligram per kilogram for, say, 2 to 4 weeks. Okay, I would taper it after that, because if it's going to work, it generally is going to work in the first couple of weeks, and I would get a spirometry to confirm that. And we often see, people don't get worse, or they have a little bit of improvement, and then you want to taper off within 4 to 6 weeks, or back down to your original prednisone dose, prednisone taper that you were getting for your other GVHD, so as not to get the side effects. Because long-term prednisone, I don't think does anything for the lungs. It just, people just build up side effects and get lung infections.
Good deal. And this person is curious about the plateau of pulmonary function. Have you seen that plateau regardless of continued medications?
Yes, that is generally the rule. A plateau is generally the rule. I will say that, so I think we're understanding that there are these probably different types of BOS. Okay, like some people will have quite a bit of improvement. That's maybe, 10, 20%. Most people will be very stable, plateau. If they're going to plateau, they plateau either immediately. And then there is a portion of people, maybe 30%, that continue to decline and don't stop declining until about 3 to 6 months after their diagnosis. And this is really, really hard. This is, the thing that keeps all of us pulmonologists awake is, how do we stop people, this group from declining? So that's where the clinical trials come in.
Cool. And is an increased occurrence of viruses or the flu associated with worsening of BOS? And is it very important to continue masking?
Okay, so we hypothesize that viruses and flu make BOS worse. It doesn't happen in everybody, but we're accumulating the evidence to suggest that yes, viruses probably promote worsening. Okay. This is shown in people with lung transplant who also get BOS. Is it important to keep masking? So my recommendation is that, everybody, you all have to live your life, and that, there are specific situations that you may want to keep masking, in very crowded situations. But I don't recommend masking as an overall thing that one must do all the time. I think it's, use your judgment, and, good hand hygiene is my recommendation.
Cool. And you showed a device that helps with bronchiolitis. What are the symptoms that this device can address?
Okay, so so I showed a little, it's a positive expiratory and expiratory device. And what it is, it's an airway clearance device, a PEP device, where you exhale into it and it creates these little vibrations. And it's really meant to help with clearance of secretions. So this is helpful for people who cough, have a productive cough sort of chronically, and have trouble getting up their secretions. It's not necessarily for everybody, but it's very harmless and actually kind of feels good. It's the other way to do it is chest percussion, is to have somebody bang on your chest to create those vibrations. And the idea is that you're helping move these secretions so they don't build up in your lower lung and cause more problems, because if your airways aren't cleared, then that can promote inflammation, we think, and worsening of disease. So for those people who have like a chronic cough and a lot of recurrent infections and pulmonary secretions.
Cool. This person would like to revisit the cold question again. Are there any recommendations you have for best way that you can help get lung GVHD back under control after having a cold?
Well, I think inhaled steroids, we think, can probably help. I don't have a lot of sort of systematic evidence to prove that, but I think that we think will hopefully preempt further worsening.
And this person would like to know, what is the standard of care for monitoring lung function after allogeneic stem cell transplant?
Okay, so I'm really glad that somebody asked this question, because the standard of care right now is different at different institutions. And really, from my opinion, really should be, well, everybody needs to have a pre-transplant lung function test. Everybody needs to have one at their 3-month discharge, whatever, day 80, 100. Should also have one at 6 months. and 1 year. If you have new graft-versus-host disease, which generally occurs around 6 months, you should get a lung function test if GVHD is diagnosed to serve as a baseline, because sometimes BOS is diagnosed at that time and it's early, and then you could do something about it. And then every 3 months thereafter for if you have any GVHD or are on immunosuppression. So these recommendations have been put forth they're in 2 documents. One is by the NIH, and we put this forth in 2021 actually as part of the NIH project on GVHD. And then there was another international guidelines that was also published, not specifically about GVHD, but about post-transplant monitoring, that also recommended, fairly close follow-up at least every 6 months. So the fact is that most centers are not following this. And I know this because I surveyed a lot of these centers who were participating in, the multi-center trials, and less than 50% of transplant centers or transplant docs actually comply with these PFT recommendations. So, a lot of this, but how would you count on anybody to know this really, or even patients to know this? But part of my role is education of transplant providers also to be like, well, you really should be getting lung function tests on people more frequently. So I hope that's the answer to that question. And I wish that the standard of care was really standard of care at all centers. And I think that overall people are getting better, but it's definitely not uniform across the country.
Awesome, thank you. And could you talk about what pulmonary rehab is and when it can help?
Yeah, pulmonary rehab is, it's done a little bit differently every place. It's a program that is designed for people with end-stage lung disease, really to help with strength, to help with techniques to help for breathing, particularly people with airways diseases, and it's a little bit conditioning. And so different places, like you can have like a 2-week program, you can have a program where you go once a week for 8 weeks. And then, you get exercises to do at home. And it definitely helps with quality of life and exercise tolerance. The people who get the most benefit out of it are people who have relatively severe lung disease. My recommendation, I recommend for my patients, regardless of how bad their lungs are, is overall rehab, which is simply making sure that you go out and walk every day. Some sort of movement for 10 to 30 minutes. And, start with small goals and then work up. So for me, that's very baseline pulmonary rehab, but specific formal programs have their, exercises and such. The unfortunate thing is that pulmonary rehab programs are not widely available, not necessarily available in all regions, and they are in high demand. And I wish that there were more of them.
Excellent. We have one that's not a question, just appreciation. Truly, thank you so much for all that you're doing. That's very nice. And then another question is, once there is evidence of cGVHD causing lung problems after a stem cell transplant, can reimplementation of immunosuppressants stop the progression of lung disease?
My belief is yes. I think that, yes, that probably does happen in many instances. So say, I know people get tapered off of whatever GVHD prophylaxis they get. But generally, if there is a new diagnosis of BOS, then, and, people are symptomatic, generally you would reinitiate prednisone as sort of upfront therapy. Though we are thinking about maybe we need to give prednisone plus another agent up front. Number one, to help smooth out the prednisone taper, but also to preempt, fibrosis. And that's what the BBOP trial is about, is that we're going to give people the belimosidil or the Rezurock up front and not wait for things to get worse before starting that agent.
Okay. And this person is struggling with GVH of the lungs. Are there any new drugs on the horizon that could help?
Okay. So any totally new drug, well, now we have axatilimab, which was just FDA approved, and I really am trying to get that into trial for people who have existing GVHD, who've, sort of run out of things. There are some pulmonary antifibrotics that are in development right now. They are not quite yet in phase 1 studies, but yes, I'm working with colleagues actually to see if we can get that one through. I mean, there's a lot of, regulatory hurdles for that, but yeah, there's a very promising antifibrotic actually that I really am pushing to see if we can get into the clinic sooner rather than later. Hard to say when, but it is going to be, unfortunately, not terribly soon. But on the horizon, the next 2 years, I think we could have a trial.
And this person wakes up some mornings gasping and dizzy, and they're concerned about if their breathing tubes may close up when they're sleeping, causing them to pass. I presume their pulmonologists say no to that one, but they're concerned that's not the case. Do you have any advice or you could provide there?
Well, so, breathing while you're sleeping is a very complex process, and being gasping and dizzy could mean a number of things, and it sort of depends on how severe one's, intrinsic lung disease is, but it could also be an upper airway thing, like sleep apnea. But, I think it would be if these are your symptoms, it certainly would be worthwhile to at least get a nighttime oximetry to see if your oxygen levels are declining, because at the very least, one could use oxygen at night. It's not good to have, low oxygen at night. So what happens really, what is more likely to close up is actually your upper airway. The lower airways, if they've already, they're just participating in breathing, and, what tends to close up when one sleeps is actually, up here in your throat and your oropharynx. So that could be part of it.
Thank you. This next question is from someone who has CGVHD of the lungs, and they've had that for about 3 years now, and they are 8 years post their stem cell transplantation. Their pulmonary function tests that they have every 6 weeks show that they are not improving and getting worse, and their inhalers hardly work. Their oncologist says they should avoid letting them put a breathing tube down their throat, as they're worried they won't survive. But they'd like to understand your opinions on how their potential next steps could look.
Yeah. Okay. So this is a hard question. I mean, I'm reading this question as, how am I going to die? With really, really bad lung disease. And, I don't know if this person is already on supplemental oxygen or, yes, suffocation is really a really unpleasant, scary feeling and sensation. I think what my so how do people with lung GVHD, how do they die? So there are 2 ways really. One is they either you get an infection like a pneumonia, which is oftentimes just unavoidable. I mean, this happens in any person with chronic lung disease. You know, it's a risk. And secondly, one can also die of primary respiratory failure, which is basically your lungs just simply stop working. And yes, that feeling of suffocation is really, really profound. If it comes to that, if there are indices, like if there's indication that your carbon dioxide levels are going up, your oxygen levels are going down, and it's not something that's reversible, meaning that, it's not like an infection that they can fix, or, something that can be helped with, a mask ventilation, non-invasive ventilation that can help you breathe, then that would be the time where you might want to use, consider opiates for relief of the, this shortness of breath. And, the problem I think that a lot of people have, or doctors have, is that because this is a really rare disease, people don't have experience in prognosticating what's going to happen. And so it's very hard to predict. And I mean, I would have to see the lung function, the trajectory of the lung function test. But if there's this one measurement, it's called forced vital capacity. If that is going down, okay, and then really, one probably only has maybe about 2 years to live. And so at this point, it's a consideration. I think it really is important to consider, well, how do you want this to look like, at the end of life? Do you want to go through, really aggressive treatment to maybe see if we can reverse something? Should, for example, if you had a pneumonia and you had to go to the hospital, would you want a breathing tube down your throat to help you through that episode, or not? Okay. And then the other thing to consider is that, if this is your primary problem and, respiratory failure is, your lungs are what's going to limit your life, are you even in consideration for a lung transplant? So again, because BOS is rare and, not a lot of people find themselves in this situation, and not a lot of doctors in the community will know how to manage this, it's just really difficult to have these conversations with people. So I hope that answers the question at least a little bit. It's a really tough question. But if one is at that point, it is really important to have frank discussion with your doctors about how you want it to, how to alleviate the sensation of not being able to breathe.
Well, thank you very much, Dr. Cheng. I think you've answered a lot of amazing questions from everybody who attended, and your presentation was excellent, and the work that you're doing is very, very meaningful and helpful. On behalf of BMT InfoNet and our partners, I'd like to thank you for your incredible remarks, and thank you, the audience, for all of your amazing questions. And please contact BMT InfoNet if we can help you in any way. And then just one last comment from the audience. Excellent information. It's much appreciated.
Thank you for allowing me to speak.
Thank you.